News. Okay. Good evening, one and all. I welcome you all to today's Navigate Medico CME program. I would like to request Professor Ajay Kumar Sood, sir, the Deputy Secretary of National Academy of Medical Sciences, to provide the welcome address.
Thank you so much. It is indeed my great pleasure to welcome the distinguished expert for Navigate Medico CME session this evening. As you know, today we are starting with a new theme, a new series of lecture on effective management of hematological disorders. And it is really my honor to welcome our distinguished Honorable Council Member, Lieutenant General Velu Nair, sir, who has also been the Chief Coordinator for this series of lecture. And he has been instrumental in identifying the topics as well as the best speaker in the country. So warm welcome to you, sir. I extend my warm welcome to eminent speaker for this evening, Dr. Abhay, sir, Abhay Bhave, sir, who is a distinguished hematologist, very famous in the country and stationed at Mumbai. And I'm sure that the practical tips which he's going to give to our students and the participants will be greatly useful for your clinical practice as well as for your examination. Welcome to you, sir, for this series. And I will also like to extend warm welcome to all the participants and our PG students who are attending this session. And I will like to make humble submission that this is the best opportunity to interact with the best expert in the country. So kindly ask your question, your queries in between, you can put in the chat box and our experts will be happy to answer that. So once again, a warm welcome to all of you. Over to you, Dr. Preeti. Dr. Preeti, please.
Good evening, one and all. Now I would like to introduce the Chief Coordinator for today's session, Lieutenant General Dr. Velu Nair, sir. He is a Group Head, Medical Services and Chief Consultant of Hematology and Bone Marrow Transplantation in Apollo CBCC, Ahmedabad. He is also the Chairman of Nuclear Accident Management Committee, Asia Pacific Blood and Marrow Transplantation. He is the Chairman of Scientific Advisory Committee of National Institute of Virology, ICMR Pune, and National Institute of Immunohematology, ICMR Mumbai. Sir was formerly the Director General of Medical Sciences, Army, Dean of Armed Forces Medical College, Pune, and Army College of Medical Sciences, New Delhi. He has also been the President's Honorary Surgeon and is the President of the National Society of Hematology and Transfusion Medicine and President of the Delhi Society of Hematology. He has been awarded the highest Peacetime Award of Armed Forces, Param Visishta Seva Medal for distinguished services. Also, he is a recipient of Athi Visishta Seva Medal, Visishta Seva Medal twice, and 20 other award of eminence, including Major General Amir Chand Award. He pioneered the setting up of the first Department of Clinical Hematology and Bone Marrow Transplantation in Army Hospital, Delhi, and 5 other centers in the armed forces. He is a leading hematology oncologist with over 30 years of experience in bone marrow transplantation and hematology, with significant expertise in treating adult and pediatric patients with various blood cancers and other blood disorders. A teacher of eminence and avid researcher with over 25 years of teaching experience in medicine and hematology, who is a teacher and examiner for MBBS, MD, and DNB, DM, and PhD in various universities in the country. He was awarded the MB Teacher Award for Excellence in Medical Education in 2014. He has published 252 international and national journals, editor-in-chief of 3 books and several chapters. It is a great honor to have you here, sir. I would now like to request Lieutenant General Dr. Velu Nair, sir, to give his comments related to today's CME.
Thank you, Dr. Preeti, for those kind words, and Professor Sood for the introduction. I'm delighted to be here, and I feel it's an honor to interact with a plethora of our future medical sciences and healthcare delivery systems in the country. That's our students. And we've already, introduced this topic. All the people who registered, many of them must be appearing for the first time. So the NAM's National Virtual Graduate Medical CME, in short called the Navigate Medico CME program, has been a huge success. We've already held 25 such lectures. And this series, the next 3 lectures, will be on hematological disorders, which oft I feel is the least covered in our postgraduate courses. From our time, things have improved, but there is still a gap to be bridged. So such sessions will help to bridge that gap. And hematology, I think, touches every other subject in medicine and surgery, because just remember, blood goes everywhere. And if you see, it's a conglomeration of many specialties put together is what hematology is. And in this series, we are covering first, most relevant thing, which is responsible for the most important morbidity, mortality stats in our country, which is anemia. So in the Indian context, it will be covered by none other than Dr. Abe Bhave, my close associate and friend. He'll be introduced later. But definitely, I would like to introduce the topics first. And the second topic will be on thrombosis, which I'll be delivering. And the third one is thrombocytopenia in critical care settings, will be given by Professor Uday from Armed Forces Medical College, Pune. So I think we will, be very happy if questions are put up, in the chat box along the talk and after that. And you pass on this message to all your colleagues so that more can join. And it's at a very meager, registration, one time of 500, and you can attend all the talks. So with those words, I'll hand over back to Dr. Preeti to introduce Dr. Abe Bhave. Dr. Preeti, please.
Thank you, sir. Now I'd like to introduce the speaker for today's CME, which is Dr. Abe A. Bhave, sir, who is a consultant hematologist in Mumbai. He's a fellow of hematology from Christian Medical College, Vellore. He's a fellow in hematology from the Royal College of Pathologists of Australasia in Australia. He's also the recipient of Dr. B.R. Ramasubramanian Award from Indian Medical Association. He has conducted anemia and thalassemia detection camps, pattern bleeding management, and DVT awareness programs. He's a sub-editor of Hematology, the Indian Practitioner Journal, Advisory Board for Hematology, JAPI. He's a former chief editor of Lilavati Hospital, Medical Times, the council member for the Marrow Donor Registry of India, member for DVT Guidelines for India, member of ICMR Guidelines for Myelodysplastic Syndrome, member for Guidelines on Newer Anticoagulants, and member for Guidelines on Pulmonary Embolism, and several national and international papers. Thank you for giving us your valuable time, sir. Over to you, sir. So you're on mute.
Thank you, Dr. Preeti. Thank you, Dr. Velu Nair. Thank you, the National Academy of Medical Sciences, for this very innovative idea thought of by Dr. Nair. Thank you, Professor Sood. It'll be a pleasure to discuss on anemia, and I would like to share my slides. I hope I'm audible and my slide is seen.
Yes.
Yes, sir.
Thank you very much for that. This is a discussion on anemia, a practical approach in the Indian context. So the flow of discussion in this meeting is going to be on how to define anemia, the implications of anemia, the signs and symptoms, how to make a diagnosis, and especially how to take a good look at the CBC. And then what are our treatment options, including certain special groups which I'm going to incorporate. So how do we define anemia? Anemia is the state in which there is a decreased production of red cells or a decreased concentration of hemoglobin in the red cells. It came from a combination of word which was called as an without, and aima is blood in the Greek language, and hence it came out as anemia and aima. We don't know the normal range for the hemoglobin in our country because ours is a very diverse culture, diverse ethnicity, and therefore getting the right range may be an issue. But in general, it is said that the hemoglobin for an adult male is between 14 to 18 and for a female is 13 to 16. So any hemoglobin which is lesser than 14 grams or especially 13.5 grams in a male would be considered as anemia. And for a female, anything below 12 would be considered as anemia. Hemoglobin in the red cell is the main player of the game. So the red cell is like a vessel which inhabits hemoglobin, which is a red pigment, which is why blood is red in color. Its lifespan is about 60 to 120 days of the RBC. The function of the hemoglobin is for transport of oxygen to the tissue and picking up carbon dioxide back to the lungs for reoxygenation. I'm hoping you can see my arrow. If not, I'll use my pointer options, which I don't seem to be able to use.
You can see your arrow.
I can see that. Okay, thank you so
Yeah.
much. So we've got a moiety which is made up of 2 alpha and 2 beta chains. This is the adult hemoglobin, and there is in the center an iron moiety. This iron moiety contains iron protoporphyrin with the iron being in its ferrous form. And this core is all intertwined in what we call as the heme, and the globin part is the protein chain which is around it. Now we need 2 more in addition to iron, which is important in keeping the hemoglobin. One is folic acid for the maturation of hemoglobin in the red cell, and vitamin B12, which activates the succinyl coenzyme A as part of the heme synthesis to be able to get a viable hemoglobin or heme molecule inside the hemoglobin. Hence, all these play a role, the iron, the B12 and folic acid. And hence you'll see in our population that it's these 3 which are mainly responsible for anemia. If you look at the data of what kind of anemia we have in our country, it is really shocking and very disappointing. This was published in the year 2010, a study conducted by the International Institute of Population Sciences, Mumbai. Around 6.5 lakh people's data was collected. And unfortunately, it showed that a very high number of children, adolescents, pregnant women in our country were affected by anemia. And a similar publication was done 3 years later from North India, where the prevalence of anemia was extremely high. And if you look at the current website of Anaemia Mukt Bharat, as of published as of 2022, every state-wise, there's a brilliant analysis done of anemia, and unfortunately, a very high incidence of anemia in all our states in our country. So in our country, almost half of the women and children are anemic, a figure that has risen in the last 3 years. And the most recent NFHS 5 data shows that the rate of anemia is increasing from 53 to 55% in women and from 58 to 67% in children, as assessed in the years 2019 to 2021. The government has made a lot of efforts, and there is a changing trend. And these efforts for anemia, or especially Anaemia Mukt Bharat, are in the form of various programs which I have shown you over here, and there are more. But these have ensured that our percolation into beyond cities into the rural areas is better, and we can give great service and prevent anemia occurring in tier 2, tier 3 and smaller rural areas. However, iron deficiency is the commonest cause of anemia, and therefore I'm going to spend a little bit more time on this as we go along. Now, one of the most important implications of anemia is in pregnancy. I think Dr. Velu Nair mentioned that this was an honor and pleasure for him to discuss with the future of India in terms of academics. Likewise, pregnancy is very important because it is going to give rise to our future generation. So our future generation should be healthy, because they are the ones who are then going to take the country forward. In Asia, anemia, irrespective of the severity, is the second leading cause of maternal death, accounting for 12.8% of independent deaths due to postpartum hemorrhage. In India, the prevalence of anemia is 58% in pregnant women, and this gets worse in the lactating women. And I'm going to allude to this as we go along, where I'm going to call it as the 4th trimester issue. In India, about 20% of the maternal deaths are caused directly by anemia, and it acts as an additional risk factor in another 50% of patients who have maternal deaths. Why do we have such a high incidence of anemia, especially iron deficiency? So it could be low iron stores, especially in pregnant women. It can be because our dietary habits are not appropriate. Maybe our food content is not good. Maybe the kind of diet which you have has low availability of iron to be absorbed at the intestinal level. It could be because we've got blood loss, such as due to parasitic load, due to poor drinking or sanitation. It can be because of the kind of issues that happen with taking non-steroidal anti-inflammatory agents, having erosions in the stomach. Piles, internal piles, are another reason for having blood loss. And maternal anemia is for various reasons that we all know, that during pregnancy, especially the first trimester, the nutritional intake is poor, and the anemia worsens as time goes along by the pregnancy itself, called gestational anemia. Now, if I give you a bird's eye view of anemia, I would start that the most important aspect is still history and physical examination. We can't go to a diagnosis of anemia without taking a proper history and examination. So if you look at the causes of anemia, it could vary from nutritional reasons that you can take from history itself, from blood loss, which you can take from history again, from hemolysis, where you can take a history of high colored urine, brown urine, dark urine, blood colored urine, having icterus or jaundice. It can be because of anemia of chronic disease. And we are going to see this because as we have better facilities, talent, methodology, our patients are going to be treated better and they're going to live longer. And we are going to face anemia of chronic disease. Hemoglobinopathy is common in our country, given its ethnicity, and therefore we have to keep it in mind. This you may not be able to pick up from history. You will need an investigation, and I'm going to show you how to go about it. Malignancies, bone marrow diseases, or toxicity of heavy metals, especially lead, are the other issues that can be there. So if I were to give you a bird's eye view, this is how you would probably tick boxes when you're seeing a patient in the outpatient or in your clinic or in your ward, that these are some of the thoughts that come to mind when you're looking at a patient with anemia. Here, for my dear students who are attending this, I would hate it if you write anemia as a diagnosis. Please remember, anemia is an event, not a diagnosis. Its cause or etiology is where the diagnosis is. So we must find out the etiology. And sometimes we all have to be a little bit like Sherlock Holmes to delve deep into an etiology and try to find the cause. And sometimes what appears to be just a simple iron deficiency may not be that, and it may be something more sinister, and time teaches you as you go along. But if you're not aware of what it can mean, then you can easily miss the diagnosis, and that could impact a patient's quality of life. And I'm going to show you some case vignettes at the end. Having pallor in a patient will only make us suspicious that the patient has a low hemoglobin or anemia. It does not give you a diagnosis. Hence, laboratory tests are extremely important. And with that, us hematologists have the big advantage of seeing peripheral smears. And I'm going to show you the value of peripheral smear as we go along. However, if my patient has type B symptoms like fever, weight loss, night sweats, a patient has jaundice, there is adenopathy in the form of lymphadenopathy or organ enlargement, I suddenly know that clearly this patient's signs and symptoms and clinical profile does not fit the routine run-of-the-mill nutritional causes like iron deficiency, vitamin deficiency, and we have to look a little bit more. It might also prompt me to want to admit the patient and do investigation rather than continue on OPD basis, which may be a little bit challenging in our country for patients to keep coming to the OPD again and again. I spoke of anemia in pregnancy and its implication. Likewise, in the older age group, like the elderly, also we look at them a little bit differently, because here the causes might be more finite than what we see in the younger age group. Here, anemia of chronic disease is more common, especially for those who are taking treatment for a long period of time for various chronic ailments. Iron deficiency is very common because they tend to have either GI bleeding because they are on NSAIDs or anticoagulants, and they don't even realize it sometimes. They can have B12 and folic acid deficiency, and then the malignant nature of it is also there, but may not be striking first. We have to think of something more simpler and then go to esoteric causes, unless the history and physical examination point you other way. Now, the first question that comes to the mind of most of us is, why diagnose anemia? I mean, why not just give blood and get on with it? So we want to avoid unnecessary transfusion. We want to do away as a group this thing which is a quick fix hematology. Give blood and get on with life. It's like putting petrol into a car. It will work for some time. Then what? Once the petrol gets over, you can't keep giving blood. Hence, it is imperative in today's world that through evidence-based medicine, we find the answer of the anemia and treat that anemia and generate our own hemoglobin. Blood transfusions are temporary and fraught with infections, reactions, and it's immunosuppressive in nature. Also, blood transfusion should be kept for those who genuinely need it, because anyway, it's in short supply, and sometimes the groups are rare, especially negative groups. It becomes hard to get blood. But there are some places where transfusion is inevitable. So I don't want you to be very, very against transfusion. It should be judicious transfusion, and patients who have a cardiac compromise, the elderly with a low hemoglobin, where the hemoglobin is dropping rapidly, or there's trauma, there is intraoperative bleeding. You can't tell them, I'm going to give intravenous iron and wait for the hemoglobin to rise. That will be an act of omission. You need to then be smart enough to give transfusion to this. So I'm for judicious transfusion rather than just. And the British Committee for Standards in Hematology has given us beautiful guidelines as to when we should give. Surprisingly, hemoglobin below 7 would be the place where we would think of giving transfusion. As it goes below 5, it would be mandatory to give blood. Between 8 and 10, most of the times, from various studies of TRICC, ABC and CRIT studies from across the globe have shown that a hemoglobin of 7, 7.5, including ICU patients, does not need transfusion unless there is a compromise. So symptomatic patients need to be transfused. For those who are doing MS and are in this group today, if there is surgery done and there's intraoperative bleeding, if it's significant, yes, you must give transfusion. But many times blood is being given by surgical teams for the process of wound healing so that better oxygen will be delivered. There is no such thing. Even if the hemoglobin is 6 gram% or a PCV of 18, there is enough oxygen delivered to the tissue for good wound healing, and therefore that should not be a reason for transfusion. In my continuation of implication of anemia, the anemia can have a different connotation. So it can be simple, as we say, iron deficiency, but the same iron deficiency can have a malignant cause inside it. So here we are looking at something called as cause and effect. Yes, effect, anemia is the effect of a cause, and if we don't find the cause, then we are not going to win. In medicine, there is a clear diktat. Pathophysiology is the way to go. Once we know the pathophysiology, it's extremely easy to make a diagnosis and then follow a proper line of treatment. Otherwise, you'll be all over the place. So getting the etiology of life, treating the patient improves the quality of life. Similarly, in pregnancy, the reason why I alluded to pregnancy and our future is because you name the part of pregnancy, whether it's antepartum, intrapartum, postpartum, and the fetal outcome, anemia can have a serious implication on the woman and our future progeny. So how do we detect anemia? It can be very vague. So if you don't pay attention to the patient's symptomatology, you can easily miss it. But a feeling of tiredness, headache, shortness of breath, a fast heart beat, feeling giddy at work, can't concentrate, cold hands and feet, people or your friends telling you why you're looking pale, loss of hair, brittle nails, sores or ulcers in the mouth and an itchy skin are some of the ones which are very obvious and kind of point towards there being a problem. But if there's going to be bleeding, if there are constitutional symptoms like fever and weight loss, I'm worried about those symptoms. And if through examination, I find that there are some other sinister findings such as enlargement of lymph nodes, organomegaly, a low blood pressure, swelling of the feet, these augur poorly, along with if there is icterus, then there is something else going on. Icterus, more often than not, points me towards hemolysis as an etiology, and my concentration of tests and thought process goes a little bit more towards that side. So from symptomatology and clinical signs and symptoms, we can actually come to some kind of a thought process inside our mind. When I'm working, I've got a kind of a set of boxes at the side. I'm kind of ticking them as I go along, and we all do something called as pattern recognition. At this point of time, I want to know what is the duration of this anemia. Is it from childhood that the hemoglobin has been, say, 9, 10, and now it's also 9? So I know from a temporal profile that I don't have to be aggressive, and I'm looking at more of an inherited cause. If it's recent onset, I'm more interested in finding out what it is less likely to be inherited. Therefore, it's extremely important to review all the past records. Unfortunately, in our country, we don't keep the record, but it'd be very worth it if we can get the records of our patients and they keep it. For our surgical colleagues who are doing surgery, they do a MOP assessment to see how much blood loss has taken place. And that's more often than not an approximation. But then knowing that there's been blood loss in the theater also helps us to analyze why the hemoglobin drops, say, from 11 pre-operatively to 9 post-operatively, and whether it's necessary to give blood or we can still manage them with intravenous iron at this point of time or with other supportive care. During surgery, sometimes the hydration is excessive and there's a dilutional anemia which can take place. And many times we don't have to chase these anemias. They usually settle down over a period of time. My last point in surgical events is that sometimes post-operatively, different consultants come at different time, and therefore the number of tests keep increasing. And hence it's been published in transfusion journals that there's a drop of 0.18 grams per day in an ICU patient in the first 5 days. We might actually have a drop of 1 gram in 3 to 5 days in our patients because of multiple blood collections itself. So what's the starting point of my anemia? CBC is one of the best ways to go ahead. And for us as hematologists, CBCs are bread and butter. That's where we start from. Without that, we are kind of no different from a physician. So from this CBC, we get a hemoglobin quantity, we get a white cell count, leukocyte quantity, and we get a platelet quantity. Now, when we look at the CBC in more detail, and that's what I want all of you to do, is look at the indices. This tells us the quality. So for a hemoglobin of 10, if the MCV, MCH is low, it becomes a hypochromic microcytic anemia. So the quality is now hypochromic microcytic 10 gram hemoglobin. If on the other hand, the MCV was high, it becomes now a macrocytic 10 gram hemoglobin. Why should we know? I'm going to show you soon. In the white cell count, we've got a differential. If the white cell count is high, is it neutrophilic leukocytosis or lymphocytic leukocytosis or eosinophilic in nature, or are there more basophils? Gives me a tremendous advantage to my thought process. So knowing the differential count is extremely important. Unfortunately, we don't have a robust quality to the platelet count, but mean platelet volume, if it is large, it indicates to me macroplatelets, and therefore these platelets, even if less, are functionally active. So from a CBC, I can get a lot of information. Also from the graphs that are displayed in a CBC, I know whether I have to look at the slide and what exactly to look for in the slide. We've moved from a first generation to second generation to now advanced generation CBC machines, which give us so much information that sometimes our general practitioners say we don't want so much. But for us as hematologists, we welcome all this information because it helps us to analyze the patient far better even before we've seen the slide. The slide might take 20 minutes to do. This report will come out in about 1.5 minutes from the machine. And today, the advanced machines give us not only the printout, but also give us stained slides along with the reticulocyte count, all automated. So the advance that is there in our bioengineering and biomedical systems has helped us to analyze anemia far better. And then we get certain normal ranges. Here, I would like to tell you about the mean corpuscular volume. It is 78 to 96, mean corpuscular hemoglobin 27 to 34, and mean corpuscular hemoglobin concentration 30 to 34. These three, along with the red cell count, is extremely important for me to make an analysis of anemia. For this entire discussion, I want to make two disclaimers. One, we assume that the WBC count is normal and the platelet count is normal. So we are concentrating only on anemia. And second, I will not be discussing pediatric hematology because it's been more than a decade since I've left pediatric hematology, and hence I may not be the right person to answer certain of those questions. So I'm sorry we have disappointed some. The mean corpuscular hemoglobin is the volume of the red cell or the size of the red cell. The mean corpuscular hemoglobin is the amount of hemoglobin per red cell, and the mean concentration of hemoglobin, MCHC, is the corpuscular concentration which is there inside a unit amount of blood. So in a 1 unit or 1 ml of blood. What does this test methodology give me? What are the parameters given by this CBC instrument? It gives me two types of parameters, the measured and the derived parameters. The measured are the ones shown here. And from then, the derived parameters are calculated by these formula, which is how we get those reports coming out of each and every one, the quantity and the quality. In addition, we get histograms for RBC, WBC, and platelets. And this therefore becomes the 3R. We also have got 3 Rs other than the film industry. We've also got a 3R, which is rapid, reliable, and reproducible method of looking at CBC. So this gives us a tremendous amount of security that we've got the correct quality assured program. Based on these indices, looking at MCV, MCH, I can now characterize them into hypo-micro, where the MCV, MCH is low, macro, where the MCV is high, and normo, when both are normal. Why do I need to know it? Because when it's hypo-micro, then as a mantra, I have got iron deficiency anemia, thalassemia, mainly minors or trait, sideroblastic anemia, anemia of chronic disease, and lead toxicity. In macrocytic anemia, see how my mantra has changed. It's now vitamin B12, folate deficiencies, myelodysplastic syndrome, hemolysis, myeloma, alcohol consumption, thyroid. My whole differential has changed. And therefore, the quality of that hemoglobin through these indices has told me that I should concentrate somewhere else. And if it's normochromic normocytic, I'm most often than not squirming in my seat because I don't have a clear-cut diagnosis. Here, it might be a combination of events from these, or it might be blood loss or hemolysis. So in an approach to anemia, I'll be looking at signs and symptoms. I'll be looking at the laboratory parameters, especially the CBC to begin with. And then this brilliant thing called CPC, or clinical path correlation. Again, as hematologists, we go to the laboratory, see our slides, makes a huge difference to us. So we can assimilate all these events and get something called as pattern of recognition. In medicine, we work on patterns. We know that if there's a hypomicroanemia and the patient's intake is poor, the patient has got piles, bleeding, the intake is poor in terms of nutrition of iron, then this is going to be most likely iron deficiency anemia. On the other hand, if there is skin hyperpigmentation, there's a bald tongue, silvery hair, macrocytosis, we know that this is going to be more likely to be a B12 deficiency. So in our minds, over the years, we've got intuition and pattern recognition. From that, our ability to hone to a lesser differential diagnosis and spend less in terms of diagnostic parameters is far better. This also helps out to go to therapy, and then we monitor. We have to monitor because we need to know whether we are on the right track and have we given the right treatment, and is our patient responding to treatment. It tells us two things: that our diagnosis was correct, and second, patient is compliant. But once you get the CBC, is there a way of looking at a clinical classification of anemia? Certainly, as clinicians, when we are sitting in the clinic opposite a patient, we are trying to put our patients into three compartments. Is it production problem, destruction, or loss? Most of the time, from history and examination, we are able to pick it up. And why do I need to do this? Because I've shown you over here how, if it's a productive issue, red cell count is low, I know that I'm looking at certain types of anomalies which can be the cause of anemia. On the other hand, if there is jaundice or splenomegaly, there's more likely to be destruction. And I've got a differential diagnosis already in my mind. I know what to look at on the smear. And if it's loss, I know menorrhagia or GI blood loss, especially in hemorrhoids, is the ones which can give rise to this compartment. And sometimes the loss compartment can give rise to low iron and therefore production. So it may be interchangeable, or there can be more than one compartments at one time. But this just helps me to decide which way am I going. Now, we've got approximately 200 billion new red cells which are generated every day, which require about 20 to 25 milligrams of iron. And it goes through a process of BFUE, that's burst forming units, erythroid, colony forming unit, erythroids, proerythroblasts, finally forming the reticulocyte, and then that goes into the circulation as RBC. Whenever there is stress, these reticulocytes come out into the circulation because there's no time to mature, and they are needed faster in the blood, so they are thrown out earlier, which is why you get reticulocytosis. About 1 to 2 milligrams of new iron is absorbed by our body. So the remaining entire amount is used from recycling of old and inactive RBCs when they get destroyed in the reticuloendothelial cells. The iron and various other vitamins are recycled, and that's why we are able to handle iron loss for a period of time before we actually develop something called as iron deficiency anemia. So if you look at this ontogeny from a stem cell to a red cell, some of which happens inside the marrow, some of it happens in the peripheral blood. So retic and red cell count can come into the peripheral blood. So you could have malignancy involving the stem cell or the earlier the BFU and CFU. PNH, pure red cell aplasia, hemoglobinopathies are all in issues which happen inside the marrow. Anemia of chronic disease also can happen in the marrow. Nutritional anemia, B12 can affect the stem cell, and the production comes down in iron deficiency, and it affects the red cell in the peripheral blood. Hemolysis and blood loss anemia are more peripheral. Enzymopathy and G6PD are more peripheral. Immune-mediated dissection more peripheral. So from the ontogeny of how the red cell is formed, in our mind, we also know probably which kind of disease process is occurring. But the kingmaker in this whole thing is the peripheral smear. The value of peripheral smear is sometimes to give me a straight diagnosis, which a CBC, mind you, never gives you a diagnosis. CBC gives you numbers, you have to interpret them. But the peripheral smear can give you a diagnosis. It can also give you a direction for investigations and therapy. So by looking at the RBC morphology, presence of nucleated red cells, the kind of cells that are present like fragmented cells, sickle cells, looking for malaria which can cause anemia, abnormal leukocytes which may be malignant reason for the anemia, or breakdown of blood are all extremely important. What I'm showing you here is a peripheral smear which shows normal red cells, beautiful central area of halo, and a nice ring of hemoglobin around it. And this is the bone marrow, which makes the red cells. So in this situation, the erythroids are inside the bone marrow, and they are producing the red cells which go into the peripheral blood. By just looking at certain slides, straight away we can get an answer. Look at this hypochromic microcytic cells. They are very poor hemoglobinization. Nucleated red cells are there. These are very typically seen in thalassemia. And the lesser the hemoglobin, target cells are here. So they are more likely going to be thalassemia major. Look at this basophilic stippling that you see in these red cells. This is typical of lead toxicity. And mind you, in my formative years in Sion Hospital in Mumbai, we used to see a lot of lead toxicity coming to us because at that time leaded petrol was used, and we had a big colony close by which catered to cars and where there were mechanics taking care of cars, and they would suck out the old petrol by sucking on a pipe. And we used to see a lot of it. Today, of course, this doesn't happen. But recently, I have seen 6 cases on a trot of lead toxicity for various other reasons. In sideroblastic anemia, what you're seeing here is 2 populations of cells, some which are hypo, micro, a little bit odd, and some which look normochromic, normocytic in nature. Some have this odd kind of Santa Claus's hat appearance, some are teardrops. So there seem to be 2 populations of cells, and this person was diagnosed as sideroblastic anemia on a bone marrow examination when there were ring sideroblasts that were noted. If you see rounded cells, this is spherocytosis. Do a direct antiglobulin test. If it's positive, it's immune. If not, and if the hemoglobin has been low for a while with a splenomegaly, this is hereditary spherocytosis. And there might be other members in the family with the same, especially with the history of splenectomy, especially in the father or the mother. If there are cells such as these are bite cells or blister cells. They are nothing but cells which have been destroyed because of G6PD, which causes a kind of a hemolysis of the red cell membrane. If you see this, these are typically sickle cells that are seen. And these are supposed to be fragmented cells or schistocytes, which are broken cells, and they augur poorly for the patients. So from peripheral smear, I can make a diagnosis most of the times, or at least I can hone my thought processes down. I alluded to hypochromic microcytic anemia. Like a mantra, there are 5 differential diagnoses. Iron deficiency anemia very typically has very like a small ring, hardly any hemoglobin in between. The same will be seen with beta thalassemia trait, but there's a little bit more of tear dropping in these. So sometimes you can't differentiate between the 2, and sometimes both exist together. In normochromic normocytic anemias, more often than not, it could be a combination of micro and macro. That means iron deficiency with B12 deficiency, or it could be hemolysis and hemorrhage. Many times we do a bone marrow examination in these patients because we are not able to get an answer unless there is obvious hemolysis or hemorrhage. Then it's a clear cut. Sometimes we have to look at the RDW, and the wider the RDW, red cell distribution width, we know that it is iron and B12 deficiency as a reason. In macrocytic anemia, sometimes we see the macroovalocytes, which you can see here. They're large. Look at them compared to these cells. They are macroovalocytes, which are very typical of macrocytic anemia, and our differential diagnosis then becomes different. So looking at the smear will help me to make a diagnosis far easier and change my differential diagnosis as shown here. There are several other tests that I can do in addition, and the list is never ending. And it could culminate in a bone marrow examination if we don't have an answer. So sometimes we have to do a bone marrow examination, especially if we are not getting any pointers from history and examination of on the peripheral smear. There is a raised ESR, there's rouleau formation, hotspots are seen on scan. Then I'm seeing some occasional blasts on the smear. I'm seeing granularity of the neutrophils being different or abnormal cells. I'm prompted or tempted to do a bone marrow examination here. or if there's a normochromic normocytic anemia and I'm getting no answer for the anemia. I'll come now to iron deficiency anemia. In iron deficiency anemia, the global scenario is that almost half of the population of the world is anemic. So we are not the only one, but unfortunately, we are one of the leaders in Asia for iron deficiency anemia based on the data that we have here. Amongst all the anemias, iron deficiency is the commonest. You'll see over here that almost 56 to 60% of our population is iron deficient. Here, I might bring your attention to the 3 stages of iron deficiency. This is a normal state where iron stores are good, ferritin levels are good, plasma iron is good, transferrin saturation is good, and the morphology of the red cells is normochromic normocytic. Iron stores, more often than not, is taken care of by a very stable glycoprotein, ferritin, which is a stable marker. It's like HbA1c. It is not affected by recent intake of iron, as opposed to serum iron studies, which could be affected by it. Transferrin is a transport ion, which is picked up in the serum iron studies. And from the CBC, you can make out how the red cells are. So the erythron can be picked up by the red cells. In iron depletion, that is, many times it is called non-anemic iron depletion, NAID, where the hemoglobin is adequate, the erythron has not been affected, the hemoglobin is still good, but the iron levels as seen by ferritin are low. For example, you can see the ferritin level is already come down to 20. It's come to the lower side. At this point of time, the iron studies such as plasma iron and transferrin saturation may not be accurately representing the iron depletion. And the erythroids, that is the red cells, remain normochromic normocytic. I wish in our country we would pick up people in the NAID, because this is where we'll win, especially in pregnancy, or those girls who are planning pregnancy. We need to pick them up here so that we can make them better iron deplete, so that they are not faced with intravenous iron or iron supplementation during their pregnancy. It'll be worth it if we pick it up here. Unfortunately, patients don't come to us at this point of time, even if we have awareness amongst our medical community. If the patient doesn't come to us, we can't treat them. We can only propagate this in the community, that iron depletion can have normal hemoglobin, and that taking iron may be an important event if we do serum ferritin levels and show that they are low. Once the iron gets depleted further, we enter into iron deficiency erythropoiesis, where the erythron mass is still good, the patient's red cells are still normal, but now there is a significant reduction, not only in the ferritin, but also in the serum iron studies. Here they are coming to you with anemia, and therefore it's not great shakes that you have made a diagnosis. Then they come as iron deficiency anemia, full-blown, where the red cells become hypomicro and the ferritin is very low, and so are the iron studies, and now we've got hypomicro anemia. I wish we could pick up patients more in the iron depletion stage. Iron absorption is very important, and one of the sole reasons why we need to know about iron therapy. When we give food iron, heme iron, which is the non-vegetarian iron, has the advantage of going through a separate transporter called heme transporter, and it goes into the duodenal, into the mucosa. The non-heme iron, or the vegetarian iron, has to be converted from ferric to ferrous state, and this is done by the duodenal cytochrome B. And then through the divalent metal transporter 1, it enters. So the entry of iron, which is obtained from non-vegetarian or heme iron and non-heme iron, is different, and it enters into the mucosa. Here, it is kept in the mucosa either as mucosal ferritin if there is enough iron inside the body, or if there's less iron, it enters through only one channel, which is ferroportin. This is the only way to enter into the bloodstream. Here, the ferrous iron is converted back to ferric iron, and this is with the help of hepafestin, which is a copper-dependent ferrioxidase. So if copper is extremely important, and copper deficiency can also give rise to iron-like deficiency. So if we did not have this, we would not have been able to convert or oxidize ferrous to ferric, because it is ferric that is then transported into the blood. It goes either to the marrow or it goes to the liver, where it is stored as ferritin or hemosiderin if there is excess, or it goes to the red cells where it goes to the erythron mass where hemoglobin is prepared. Now, there is a system of controlling the iron. Hepcidin is a protein which controls ferroportin. So if there is excess amounts of iron, or if there's enough iron in the blood, hepcidin will give a negative feedback mechanism to ferroportin to stop the absorption of iron, in which case iron coming in will be collected as mucosal ferritin, and it will be lost by shedding from the epithelial cells. This is the iron curtain, and this is one of the brilliant examples of nature, how it has helped us to take care of our iron. So there are therapeutic oral iron preparations available. There are several salts. If you open MIMS SIMS, you will get in excess of 140 preparations available. Intramuscular iron preparations, I have not used for more than a decade, but I have definitely shifted more and more often to intravenous iron for a certain cohort of patients, and I'm going to tell you which they are. I think oral iron tablets is more like a sasta, badhiya, tikau, mazboot, sundar way of treating iron deficiency in our country. There are several salts. I've shown some. There are many more. About 60 to 100 milligrams of elemental iron per day is needed. There is a concept of using alternate day, and I give the iron after food rather than fasting. I see the compliance to be far better. There are problems of side effects such as nausea and non-compliance. And they tell me that they'll take an iron-rich diet. Remember, iron-rich diet is supplemental, not therapeutic. When there is anemia, you need therapeutic intent, and I have to make that clear to my patient that please take these tablets, or if you can't handle in terms of compliance, shift to more parenteral forms. So parenteral iron therapy has become more safer, less toxic, and these new ones are very effective. And I'm talking more of the intravenous rather than the intramuscular ones. So I've got cohort of patients who will do well on parenteral, that is intravenous iron. Those who are intolerant genuinely to oral iron therapy, those who got a malabsorption syndrome, those who have had an intestinal resection surgery, those who are in the third and fourth trimester, you heard me right, that's called postpartum anemia. It's been called as the fourth trimester. So third and fourth trimester, where you want a rapid increase in hemoglobin. Post-operatively, to reduce the transfusion need, extremely well published in surgical and medical journals. Those who have got heart failure secondary to iron deficiency, that improves the cardiac function. Iron deficiency in renal patients. And those who have got a religious belief that they will not take blood, such as the Jehovah's Witness, they can also do with iron deficiency. All these, you give the parenteral IV iron therapy, provided you have documentation that there is iron deficiency. You will not give it on speculation. A simple ferritin or serum iron studies will help. In pregnancy, parenteral iron has made a lot of difference because the girls just cannot tolerate oral iron, and the requirement of oral iron is significant. It's 100 milligram per day in the initial in the initial part. The requirement is 0.8 milligram per day. So up to the second trimester, they're going to need a significant amount of iron. They do try to take oral, but many times they cannot handle it. As they go into the second and third trimester, later part of second and third, this requirement increases to 7.5 milligram per day. And therefore, many times you will need intravenous iron preparations in those girls who got a less hemoglobin or they cannot tolerate oral iron, parenteral iron at this point. So 9 times higher requirement of iron is needed during pregnancy, and sometimes oral iron cannot handle it. And don't forget, there's going to be lactation followed by menstruation later on. So we need to make them replete, and parenteral iron makes a lot of difference. In anemia of pregnancy, it may not only be iron deficiency, it may be various other reasons. It could be a physiological anemia of pregnancy. Usually we see that by the second to third trimester, never in the first trimester, unless they're already anemic to begin with. If they are developing physiological anemia and the hemoglobin remains above 10, usually it's observation, and we continue with iron therapy because of the iron deficiency that takes place as part of pregnancy. If there is an iron deficiency, we treat it more aggressively. If they're not taking iron, we'll give iron. If they're taking oral iron, we can go to intravenous. Look for any hemoglobinopathies at this point of time. So here we can do ferritin, iron studies, vitamin B12, folate, and we can do by HPLC for hemoglobinopathies such as thalassemia if it has not been detected before. However, if there's a rapid drop in the hemoglobin, especially in the first or second trimester, you have to think of something else. There might be bleeding, antepartum hemorrhage, or as we come towards the second trimester, HELLP syndrome and other pregnancy-induced hypertensive changes can be important. And we have to be wise that this anemia is not only iron deficiency in nature, it might augur poorly for the patient. In such situation, looking at the peripheral smear for schistocytes or broken cells, seeing whether the blood pressure is rising, looking at the liver function test for abnormalities in the liver enzymes, which can help us to diagnose HELLP syndrome or pregnancy-induced hypertension, looking at the coagulation profile to see whether they're going to AFLP or going to TTP or HUS is very important. So these hypertensive disorders become more obvious in second to the third trimester. And here the decision of actually stopping the pregnancy and delivering may become very important. Here, smear examination is important, and sometimes we may do plasmapheresis if it's TTP or HUS to buy time till we take a decision for the delivery. And the other cause of anemia is postpartum hemorrhage, which sometimes occurs in patients, especially if the fibrinogen level is less than 200 at the time of delivery, then that's a very fine indicator that the patient might go into PPH. So if you look at anemia in a cohort like pregnancy, you will have such a plethora of events which might be a cause of anemia. So like I said, it could be sinister, it could be simple, and therefore we have to give it all our thought and knowledge during the management. Most of the times it is iron deficiency in our country, and most of the time we will get away with iron therapy. If the hemoglobin starts going below 7 in pregnancy, then we start questioning, why should we not give blood? If it's above 7, we question, why should we give blood? So our question and intention keeps changing based on the patient's dynamics and the hemoglobin result. Second trimester, third trimester, and in the postpartum, that is fourth trimester, is the brilliant time where we can use parenteral iron therapy if there is no other reason, and it's only iron deficiency, to bring up hemoglobin. It's very important that in this phase, in the pre-pregnancy or first trimester, we are able to pick up thalassemia and do it in the spouse also, and then we should look for evidence of any other causes. It would be nice if we could pick up in the pre-pregnancy state anemia and treat it. If it's thalassemia, pick it up, because it makes a lot of difference. So I want to impress you that anemia is a moving target, not only in pregnancy, but in most other diseases, but more so in pregnancy. And everything changed with intravenous iron. We've got the first generation, second generation, third generation. And the reason they became third generation, because they got better and better in terms of the nanoparticles. Their core is made up of iron oxyhydroxide, which is mainly ferric in nature. And it is covered by a carbohydrate moiety. And the different names that you see in market are because the carbohydrate moiety keeps changing. And it's this carbohydrate moiety which gives it the differences in immunogenicity and its stabilization. And it is its unique feature. So we've got iron sucrose and ferric carboxymaltose, which is available. There is iron isomaltoside also available in the market, and I've started using that also. There is a method to calculate how much iron is needed, except that iron sucrose, you'll have to give it in shorter amounts of time. So the patient has to come more often to the hospital. So 5 times if you want to give about 1 gram. Unlike that, the current available carboxymaltose and isomaltoside, you can give larger amount of doses in a shorter period of time. And therefore, this can also be done on day care basis. In most of the Indian pregnant women, a dose of about 1000 to 1500 milligrams is well suited. I have so far used only ferric carboxymaltose in pregnancy. I have not used isomaltoside so far in pregnancy. There are dilutions which is available for the amount, and it's there in the product insert of each and every intravenous iron preparation, and we should allude to. And we should also know some of the side effects that are available occur along with it. And most commonly, what we see is the 6H syndrome, the hyperphosphaturic, hypophosphatemic event, which is triggered by high fibroblast growth factor 23 that causes hypovitaminosis, hypocalcemia, and secondary hyperparathyroidism. Just to convert this Greek and Latin into English, it means the patients have leg pains, cramps, joint pains, and many times fever, and they feel unwell. That's what it means. So this is the 6H which can occur, especially with ferric carboxymaltose. I am told that this incidence is much lesser with isomaltoside. There are some clear contraindications to the use of parenteral IV iron. If there is hypersensitivity to any of the compounds, it should be iron deficiency and not otherwise. There should be not an iron overload, so don't give iron on speculation. In pregnancy, in the first time, it is not studied, and children below the age of 14, it's not been studied. Fourth trimester is a neglected health issue, because here there's a baby born. Everyone's attention now goes to the baby. The mother is forgotten. The mother may have had some hemorrhage, may be anemic during pregnancy. She's not taken enough during pregnancy. Her pregnancy might be closely spaced. She might be having multiple births. And at the end of the day, she has also got to breastfeed the child. So mother's iron status must be evaluated prior to discharge in the postpartum anemia. And here again, the role of IV iron is good, because I don't know whether when they go home, they'll have time to have that oral iron. And if they have any kind of GI upset, they're going to stop taking the iron. And this has been also told by our Indian experts. There's a plethora of Indian experts who published this last year in June in the Journal of South Asian Federation of Obstetrics and Gynecology. And the same thing has been said, that intravenous iron or parenteral iron seem to be optimal in the second or third trimester, and even including postpartum anemia, to bring up the hemoglobin. And there's been a rise of hemoglobin by about 3 to 4 grams in many of these patients. So if you look at Anemia Mukt Bharat guidelines of 2018, we've got that oral iron and 100 milligram is worthwhile to be given along with 500 milligram folic acid to prevent neural tube defects. And we should give that. If not, if they're not able to handle it because of compliance, IV iron sucrose or ferric carboxymaltose has been used. If there's no improvement with oral, then they have to be referred to a high health facility where if you're not able to give IV iron or they have not responded to IV iron, then they should be managed with further investigation, or if they're not received IV iron, to take IV iron at that point of time. As the hemoglobin becomes more severe, there should be immediate hospitalization, especially if it's third trimester, where we can give specialized care, including transfusion if needed, or we can give them, if they are stable, we can give them IV iron at this point of time. In the postpartum also, the FOXI has given us guidelines, and in the postpartum, we can use parenteral iron as a bolus dose and as a short infusion. And this has got a grade A level 3 or level 2 advantage in the postpartum phase. I'm going to quickly come to thalassemia trait. This also is hypochromic microcytic, and we have to know because we've got a large ethnic community which can have thalassemia trait. And usually these people are unnecessarily given iron from one company's iron to another company's iron. In India, what I have found is the usual hemoglobin is between 9 to 11, but this might vary. I've got some patients who've got 8, 8.5, and some who've got a 14-gram hemoglobin with thalassemia minor. This is picked up by hemoglobin electrophoresis by HPLC, where the A2 is raised and usually above 3.6 typically, although some take 3.5 as the cutoff. We can do a DNA analysis for gene mutation. We can actually find the correct gene which has caused the thalassemia trait, and this helps us in genetic counseling. Since both thalassemia minor or trait and iron deficiency anemia are hypomicro, we need to give you some kind of a clue in the CBC. So if you've got a quality assured CBC that is coming to you in a printout, we can pick up that a low hemoglobin is common to both, but a normal or raised RBC and a normal MCHC differentiates thalassemia trait from iron deficiency anemia. So if you've got 5 parameters and all 5 parameters are low, this is more likely to be iron deficiency. If it's a raised RBC, a normal MCHC, this is more likely to be thalassemia. I wish life was that simple. In practice, we get a combination of both, a thalassemia having iron deficiency and a person of iron deficiency who did not know he had thalassemia minor. The question asked to me many times is, should I give thalassemia minor or trait iron therapy? My answer is yes. If there is proven iron deficiency, that patient has the right to take iron only if it's proved to be iron deficient. When we say minor, it's between 9 and 11. When we say intermediate, the hemoglobin is usually between 7 and 9. And when it's less than 7, it's usually major. And most of the time, major is picked up when they are 3, 6 months or 7 months of age, needing transfusions from that point of time. There is a way to go about this. So in your practice, look at the MCH. It's a very good way of looking at things. If the MCH more than 27, if the ferritin is normal, this is unlikely going to be iron deficiency. If you do a hemoglobin electrophoresis along with it and it's normal, thalassemia is out except for alpha thalassemia. As simple as that. If the MCH is low, less than 27, ferritin is normal, again, it is unlikely that there is iron deficiency. But if the hemoglobin electrophoresis shows a raised A2, this is likely to be a carrier for beta thalassemia. If it's normal, it can still be a carrier for alpha thalassemia. And if there is sickle or hemoglobin D or hemoglobin E, then it's a hemoglobinopathy that is there. If the hemoglobin electrophoresis come normal, don't forget that it could still be alpha thalassemia. If on the other hand, the MCH is low at less than 27 and the ferritin is low, this is most likely going to be iron deficiency anemia. However, a thalassemia may coexist, and that's very important to replete the patient with iron and then do the thalassemia test so that your chance of getting a false negative is good. So in the antenatal clinic, extremely important that we look at both partners and see what is the status of thalassemia. So if I have a patient of hemoglobinopathy who's come to me, I look at the serum ferritin. If the serum ferritin is low, I give iron. However, if the patient coming to me has an unknown hemoglobinopathy status, I don't know whether she's thalassemia, then I look at the indices. If they're hypomicro, I give a trial of oral iron. This is considered as grade 1B recommendation. I give a 3 weeks period of iron. If after 3 weeks of oral iron, which is compliant, I look at whether the hemoglobin has improved. If there's no response, I look for other causes of B12 and folic acid, which may be hidden. If not, then I do the thalassemia study. At this point of time, some of my obstetric colleagues say, look, we don't have 3 weeks to wait for your iron to work. And therefore, can we do something earlier to know whether she has thalassemia tray? I do the spouse's thalassemia status. If the spouse is thalassemia negative, that means doesn't have thalassemia minor, it makes no difference to me whether the patient is thalassemia minor or not. But if the spouse is thalassemia, beta thalassemia tray, I am worried for that patient. I will be doing the thalassemia status for this patient. In fact, I might do a gene. I don't have to wait for 3 weeks. I might do a gene test of both of them and see what is happening in the growing fetus. Remember, we could also be held responsible for the birth of a thalassemia major, because it is our job to check whether the couple is thalassemia tray or not. Coming to the next one, which is megaloblastic anemia. It is common, extremely common in our country, but maybe not as common as iron deficiency anemia, because the loss of B12 is available from most of the foodstuffs, but unfortunately, or fortunately, we've got a very good store of B12 and folate. So it takes a long time for it to become manifest. And basically, we can pick it up from history and skin hyperpigmentation and a bald tongue. This is poor diet, being purely vegan is a very, very potent history for B12 deficiency. Skin hyperpigmentation over the knuckles, around the mouth, a bald tongue, give way sign, silvery hair, give way sign. And if you see macrocytic anemia on the CBC with the raised MCV, macroovalocytes on the peripheral smear, the LDH is raised, showing ineffective erythropoiesis, and a raised indirect bilirubin, you really don't need any other investigation. So you can just give B12 therapy to them and see whether they respond. You can do an active B12, a holotranscobalamin, or a folate level, and that can also confirm your diagnosis. For those who are non-believers who want a documentation of B12, you can do that. You can use intramuscular replacement. Fortunately, I've gone to sublingual replacement with B12 as a strip which can be kept just below the tongue, and we get good results with it. And don't forget to give folic acid simultaneously. Many times we do intrinsic factor antibody and antiparietal cell antibody because they might be part of an autoimmune profile, and sometimes there could be pernicious anemia. So we may have to give B12 for a longer period of time. We may have to do endoscopy and see whether there's a gastric achlorhydria, because these people are more prone to malignancies of the stomach in the future. And therefore, it's very important to do a check endoscopy once in a while. I've seen in practice that many of these B12 deficiencies are associated with diabetes, especially those who are taking metformin, because B12 deficiency takes place. Hypothyroidism, vitiligo, these all come together sometimes in patients with autoimmune diseases, and maybe B12 is the initial manifestation. Look for the others and you might be able to do more preventive medicine. The other cause of hemolytic anemia, in hemolytic anemia, there can be two types, autoimmune and non-immune. In autoimmune is usually the direct antiglobulin test or the Coombs test, which is positive. There could be an associated indirect Coombs test, but DCT is very important, or DAT. And here again, the bilirubin LDH will be high, the haptoglobin will be low, and the bilirubin will be indirect in nature. But sometimes this hemolysis is not immune in nature. And in our country, we've also got sickle cell anemia. There are 4 genotypes of sickle cell, which can be seen in practice. But sickle cell tray is also important because this is usually asymptomatic. It is not serious, but sometimes over a period of time, the sickle cell, by virtue of the breakdown and little bit of release of the sickle hemoglobin into the blood, it can give rise to hematuria and isostenuria, where the osmolality of the blood and the urine is the same. And this could be seen in patients with renal papillary necrosis, and it might give rise to nephropathy in the future. So everything is not hunky-dory with sickle cell tray. We need to take care of them, especially during pregnancy. These sickle cell anemias, whose hemoglobin S levels are more than 50, are the ones which come to us in practice, and who come with vaso-occlusive crisis, which can come at various sites, which I've shown over here. And therefore, it is our awareness which will help pick it up. One peripheral smear, you see the sickle cells, and your diagnosis is made. As simple as that. So that's the power of a peripheral smear over a CBC in such patients. These patients need good hydration, prevention of acidosis, prevention of infection, and oxygenation, all of which are potent causes for sickle cell crisis. In practice, many times we get combinations of deficiency, and we need to use combinations. There are other inherited or stem cell disorders which are cause of anemia. I don't have the privilege of going to them because it will take too much time. But G6PD deficiency, which is seen in some communities in our country, where there is a rapid drop in hemoglobin because of exposure to a certain inciting antigen or agent like a drug, hereditary spherocytosis, and other membrane defects. Now I'll turn towards what is refractory anemia. Sometimes despite your good history taking examination, CBC, investigative methodology, you might still have a patient who does not improve and in fact is heading towards transfusions quite often. So these are anemias who are non-responsive to standard therapy or who are not related to common causes of anemia. That means you've ruled out in its true essence reasons for anemia and still the patient tends to have a low hemoglobin. So there can be various ones which I've shown you over here. And in these, more often than not, we need a bone marrow examination. One of these causes of refractory anemia is anemia of chronic disease, where the indices are low and actually they behave like sometimes like hypomicro, but they are not iron deficient or thalassemia. Erythropoietin here is a drug of choice, and they really do very well with erythropoietin or with darbepoetin. And in those who are anemia of renal disease, there is a new drug which is making a lot of difference, that is desidustat. It improves the hemoglobin very well in these patients. So how do we recognize this anemia of chronic disease? And if they're hypomicro, how do we differentiate it from thalassemia and iron deficiency? Well, there is a way of doing things. Now, if you look at here, there are 3 columns of the 3 ones which are all kind of low hemoglobin, and more often than not, their MCVs are low. So they are mainly microcytic and also hypochromic. Look at the red cell distribution curve. In thalassemias, it's usually normal. Look at the TIBC. It's usually increase in iron deficiency and decreased in anemia of chronic disease. And look at ferritin. In iron deficiency, the ferritin is decreased. And in anemia of chronic disease, it is increased. So if you have a low ferritin and a high TIBC, more often than not, this is anemia of iron deficiency. If it's the other way around, it's more likely to be anemia of chronic disease. Now, you could have both coexisting, so sometimes it becomes difficult. And here, you can do the soluble transferrin receptor. It could be increased in both, but it means that there is a functional iron deficiency, and such people do very well. The soluble transferrin receptor is high. That means there's a lot of receptor yearning for iron, waiting to iron to be captured. Then they do very well with parenteral iron therapy. And you'll see a lot of your renal patients receiving erythropoietin plus intravenous iron therapy. And now many people will also be taking desidustat. Bone marrow is fantastic. Sometimes it picks up things like aplastic anemia, a tuberculoma that you see over here, a paratrabecular aggregate of lymphocytes, hemophagocytosis, secondaries in the marrow. So really, it's like a Pandora's box, and sometimes new things are picked up which you didn't expect on the bone marrow examination. I would say assessment of therapy is extremely important. If you see that your indices are improving, your hemoglobin is improving, reticulocyte count is coming up, it's important. I haven't spoken about the reticulocyte count, but retic is very important. A rising reticulocyte count is a good response to hemoglobin. So there are 3 H's to reticulocytosis: hemorrhage, hemolysis, or hematinics. So if hematinics has improved and there's no hemorrhage or hemolysis, then you know that this rise in hemoglobin, rise in reticulocyte count is because of the therapy, that is the hematinics. I expect about 1 to 1.5 gram per deciliter of hemoglobin rise at about 2 weeks' time. The performance improves. But if I'm not getting this, I need to go back and see whether my diagnosis was correct. There's no shame in going backwards. I'm coming quickly to some case vignettes so that we can end this discussion. This is a 19-year-old girl who's got symptomatic anemia. She's got no constitutional symptoms. Her hemoglobin has been low for the last 5 years. She's taken multiple iron therapy and recently even B12 therapy. This is her CBC. If you've got a pen and paper in front of you, look at this hemoglobin and just put down your thought as to what it might be. You're looking at anemia, which is hemoglobin 9, which is hypochromic microcytic with a normal MCHC. MCHC is normal. The RBC count is also normal, 5.9. In fact, it is on the higher side, and the WBC platelets are fine. In this situation, just let's write down what you think came first to your mind. I know you want to do, because hypomicro and the RBC count is normal, you want to do a hemoglobin electrophoresis. Here, you expected the A2 to be 3.5 or 3.6 and above to make a diagnosis of thalassemia, beta thalassemia trait. Remember, alpha thalassemia will not be picked up on a hemoglobin electrophoresis by HPLC. Your iron studies you did were normal. B12 is normal because already patients received B12, and there's no bleeding or drugs that could interfere or cause anemia. Now you're stumped because your hemoglobin A2, you expect it to come high and it's not. Well, this patient actually has an alpha thalassemia where the A2 is low. So in a clinical pointer in practice, if your A2 level is below 2, think of alpha thalassemia, and you can prove that by DNA PCR. This is a 39-year-old man who's got a symptomatic anemia. Again, nothing much in terms of symptoms. He's been low hemoglobin for the last 3 months. He's received iron and B12 therapy, and there's been no response to this patient. If you got a piece of paper in front of you, I would like you to look at it. Hemoglobin is 7. It is normochromic normocytic, normal MCH. RBC count is low. So this is a hypoproductive anemia. WBC and platelets are fine. So this is anemia which is normochromic normocytic. This augurs a little bit differently for this patient, right? Because we expected hypomicro for our differential diagnosis. You did anyway his hemoglobin electrophoresis. You did the iron studies, B12. There are no drugs or bleeding in this patient. And now you don't know what to do with this patient because all the common things that you had in practice, you've done it and we've got no answer. They are the type of patients who are normochromic normocytic, where I alluded to the fact that bone marrow examination will be important. And this patient actually had a pure red cell aplasia, and the giveaway was here. The RBC count was low, indicating a hypoproductive anemia. Of course, I had the advantage of seeing the peripheral smear to see that there's nothing else in terms of hemoglobinopathy. Many times, this pure red cell aplasia is associated with thymoma. So do a X-ray chest or a CT of the chest, and you can pick up whether there's a thymoma. You remove this thymoma, look for malignancy in it. More often than not, the pure red cell aplasia will settle down completely. This is a 72-year-old gentleman who's a retired professor. He's got severe fatigue and loss of appetite. He's now got dark urine. He appears jaundiced, and he's got admitted with you because he's needing blood transfusion. He's symptomatic. You send the sample for cross-match, and there's no blood available. They are saying we are not able to cross-match. His hemoglobin is 6.9. His WBC count is 65,400. Platelets are 132,000, little bit less than normal. MCV is normal. His absolute lymphocyte count, to your chagrin and amazement, is 47,000. Most of his cells are lymphocytes. You saw his peripheral smear, and you saw many lymphocytes which are mature-looking lymphocytes. You did his direct Coombs test because you were wondering he's got jaundice, he's got a dark-colored urine, his hemoglobin is dropping rapidly, so you needed to rule out hemolysis. And sure enough, direct Coombs test came positive, direct antiglobulin test. His immunoglobulin level was low, and his retic was high. I told you 3 H's: hemorrhage, hemolysis, and hematinics. There's no hematinics here. There is no blood loss here. So this is hemolysis. So this explains that there is some hemolysis going on. But we did a flow cytometry for this lymphocytes, and we picked up chronic lymphocytic leukemia. He never knew about this. This is his first presentation. So he actually has a CLL, which as part of its process of biology had produced a direct antiglobulin test, which caused hemolysis to drop the hemoglobin. There was no palpable lymphadenopathy, no organomegaly. That means this CLL at 65,000 is not the reason for his problem. It's not that I have to treat the CLL. So I actually treated his hemolytic anemia by giving him steroids and immunoglobulin with a brilliant response. His WBC came down to 38,000, and his hemoglobin went rushing up to 12 gram per cent at the end of about 2.5 weeks of treatment. This is a 32-year-old gentleman who's asymptomatic other than complaining of fatigue, recurrent iron deficiency anemia. This is his 3rd episode when he came to me. Every time he's responded well to oral iron, only for it to drop again. What do you do in your next step? You continue the replacement of iron because he's responded well in the past. You observe and say, look, let's just take oral iron-rich diet and see how it happens. You do an endoscopy and try to find out why is he getting it again and again, and do a blood test for malabsorption because maybe there is gluten allergy and that's why he's not absorbing iron. So if you've got a piece of paper, please write down which option would you have liked over here. So I'll tell you what my option was in this patient. I'm not going to continue iron replacement because this is his 3rd episode. Yes, he's improving, but that's not the way it is. I'm not going to observe him with food and dietary or nutritional supplement. I'm going to do his endoscopy. I'm not going to do his test for malabsorption when I can do an endoscopy because that's a much better way. And you'll be surprised I found CA colon. It was resected. And thanks to that endoscopy, we did not have to give him chemotherapy. It was resected and he's fine. It is now 6 years and he's not had any recurrence. You made a huge impact to this patient by your awareness so that you could pick it up. Otherwise, this man, if it had spread, would need chemotherapy and would affect his quality of life and even longevity. My second last case is a 63-year-old female who is a housewife. She's had a fatigue for the last 1 year, but then ask any housewife, this is a common complaint that they have. There's no transfusion before this. The low hemoglobin has been since the last 3 readings over the last 6 months. It's been coming down gradually. There's reduced appetite. There is knee pain, and she sometimes gets abdominal pain off and on. When I examined her, she had a hepatosplenomegaly. Her hemoglobin had come down to 9.3. WBC count was just about there. 4,000 to 10,000 is normal. She's normal. Platelets again just about there. 150 to 400 is normal. She's 153. But I told you we have an advantage of looking at smears. Nucleated red cells were 10 per 100 WBC. I like to tell you that not a single person should have a single NRBC in the peripheral smear. That augurs poorly. There is a pathology. You have to look for it. MCV was normal. Differential was normal. There were no blasts or malignant cells. Liver function test and creatinine was normal. So it's not like it was a chronic liver disease which was giving rise to hepatosplenomegaly. Now I told you that as hematologists, we have an advantage. Look at these cells here. They are teardrop cells. When I saw these cells, I knew something was wrong. These teardrop cells come up with a different diagnosis. That's primary myelofibrosis. This is almost like a pancytopenia, but predominantly it is anemia. Hence, I've included in our discussion today. I did a bone marrow and look at what I see here. There are sheets of fibroblasts. And if I do a reticulin stain, look at this fibrous tissue which is inside. This is primary myelofibrosis and dilated sinusoidal vessels because the fibers pull it apart. And that's why these sinuses, which are normally closed and not seen, are seen more easily. Classical primary myelofibrosis. You started with anemia and you got a diagnosis of a malignancy. It's only purely because you had the awareness. I think my last case, this is a 68-year-old gentleman who's had a weight loss of about 10 kilograms over the last 6 months. And this was probably because of the lockdown. He has had no blood loss, obviously, anywhere, but the hemoglobin has dropped from 11.8 to 6.5. And he got a transfusion done. Post-transfusion hemoglobin was 10, but as part of the analysis, stool occult blood came positive. He'd already had one endoscopy, but then we wanted the endoscopy to be repeated. Here, a repeat endoscopy, whether it's upper GI or lower GI, sometimes has an added advantage of picking up in 30 to 35% cases, something which you may have missed in the first endoscopy. So doing a repeat endoscopy, although the patient will not be happy, is very important or vital to get a diagnosis. What we picked up here was angiodysplasia in the colon. So sometimes as part of age or as part of disease, there are vessels which kind of bunch up and the pressure goes up in them and they bleed. And it could be hereditary hemorrhagic telangiectasias, it could be angiodysplasias, but these bleed and the patient develops anemia and they come for transfusions. So the answer is to actually give them treatment for angiodysplasia. If it's local, we can actually do argon laser and stop the bleed. But if they're multiple, sometimes you can't do anything about it other than giving imids like thalidomide can be used. There's a new drug called bevacizumab. It has its own problems, but it has been used for angiodysplasias to stop bleeding, especially in those who come recurrently to us. So I'm going to stop my discussion at this point of time to say that sometimes, anemia sounds so easy, but you don't get an answer. And many times you need to have a discussion with your colleagues, pick up the phone, make a call to the pathologist. If you're seeing slides, go back, revisit the slides, or talk to your colleagues. I've called Dr. Velu Nair often to discuss my patients with him. He's been kind enough to take my call, and I've been wiser. And sometimes by this discussion, there is some brilliant idea which comes up which might make a difference to your patient. And I don't care who makes my patient better, whether it's me or my colleagues. As long as the patient gets better, we are all very happy. I'll conclude by saying that anemia is an event. Anemia is an event. It's not a diagnosis. Every specialty will face it. So my surgical students who are also here, you will also face anemia. And my answer to you is, my request to you is not just give transfusion, but either find out yourself or refer it to your physician colleagues to see that you get a proper diagnosis. Don't miss a hemoglobinopathy, especially during pregnancy. Have a stepwise approach with an automated CBC and a good peripheral, well-stayed peripheral smear. Those MD students who intend to take intensive care medicine, Please learn to see slides, because at night there might be no hematologist or pathologist in your center. You'll have to go down and see the slide for schistocytes, which can change your management, malignant cells, or hemolysis. At least these 3-4 things, if you can see and try to identify, it might be a great thing for you in your practice. You need to look at the pathophysiology, use evidence-based medicine. Don't give transfusion unless it's judicious. Replace with whatever replacement you can give to bring up the hemoglobin. If it's needed, do a marrow examination as per the indication and correct the underlying cause. And don't forget to check the response at regular intervals to see whether you were right. At this point of time, I'm saying for iron deficiency anemia, parenteral iron with its availability in a much cheaper form, safer form, is gaining importance in our country in different cohorts, which I've shown you. Thalassemia should be detected early. We don't want to have a birth of a thalassemia major child, because the implication is very big to that young couple. And I've seen couples breaking up. Using an algorithm to understand thalassemia is very important. And some areas are endemic to sickle. Don't miss it, because otherwise you'll be missing the pathophysiology and they'll come to you recurrently with the same problem. You could also see my approach to anemia clinician's view on the JP Publishers website. And I'll end my discussion here. I'm very sorry if I've exceeded my time, but I had requested the permission of Dr. Velu Nair that I might exceed 5 or 7 minutes. And I'm going to stop sharing at this point of time and hand over back to Dr. Velu Nair. Thank you for listening to me.
Thank you, Abhay. Actually, being a hematologist of some years standing, I thoroughly enjoyed your lecture. Let me first tell you that. And I have learned. Let me also tell you that. So, dear students on the platform, you couldn't have got a better exposition on approach to anemia, which is so complex, which is thought to be common, is the most complex actually, and we take it for granted, but we very often don't know how to approach it, and we just live with it. And what Dr. Abhay has done today is a fantastic exposition how to approach this whole problem, especially in our country. And every anemia, not iron deficiency anemia, number one, so it may be the commonest. Having said that, I want to highlight, which I don't miss an opportunity to do, how does hematology differ from other subjects? Just the difference of a microscope which a clinician goes to, which I don't know of other subjects unless it's a passion he or she goes to. But here, if you don't go to it, you won't pass your exam. That's the first entry point. And thereafter, it adds so much to our lives. And he's so beautifully brought out CBC and PBS and how each one complements each other and how you can actually add to all your high-tech investigations. But the peripheral smear stands alone as a peripheral smear. Okay? He covered all types of anemia. And he gave you case fitness at the end of it, which highlighted each one of them in the diagnostic requirements and the management skills. He also highlighted to the surgeons and others the requirement of transfusions when you have to give it and when you may avoid it, and when you need not give it, and when you should not give it. Most importantly, in anemia, when do you actually say and decide, I have to do a bone marrow? That's so important, which is so nicely and effectively covered. I would fail in my duty if I don't say he so nicely highlighted how to pick up your thal on a CBC and on your printout from your counter clip, which shows you parameters that you read out. And he told you the importance of the RBC in an anemic patient of RBC, MCSC, and the RBC, the count itself. But how you can say, okay, this is the patient I want to see further. And further, he told you what to do. So I think he's covered it beautifully. And I would welcome any questions. And there's one question from Dr. Shruti. Sir, patients with sepsis and iron deficiency, should we defer iron therapy until they are out of sepsis?
I think that's a very,
Very good question.
very good question. And it is something which we see quite often in practice. So my answer is yes, I have avoided giving iron therapy to patients in sepsis. My premise is, and I would love Dr. Nair also to give his opinion. My premise is that sometimes in sepsis, the organisms also use iron for their own growth. And remember, iron is a ubiquitous element on this planet. Our core of the planet is iron. So every being, it's not only hemoglobin, it's every enzyme of our body also needs iron. It's a very ubiquitous protein. So even the bacteria are going to use the iron, and therefore I'm a little skeptical about using iron therapy when there's ongoing infection. I tend to defer it till the infection is better under control. There's adequate antibiotic given to the patient, and then it's never urgent to treat iron deficiency because it's going to take you 7 to 10 days to 14 days for the hemoglobin to rise. In this situation, if the sepsis is severe, I might use actually transfusions to bring up the hemoglobin rather than give iron. But that depends upon the clinical situation. Dr. Nair, your thoughts?
Thank you, Dr. Abe. I agree with Dr. Abe. I will go a step further to say I never give iron when there's anemia with sepsis. I will avoid it for the reasons he said. That's very true. Number one. Number two, we have seen patients worsening when people have done that. Number three, we've said, you have to take each patient is different. And, depending on his comorbidities, depending on what he's in the ICU for, transfusion is the way to go here. Though transfusion itself has iron, but that's a safer iron than giving IV iron. So the answer is no IV iron, and go the way of transfusions if indicated as explained before. Good question. Thank you. Okay. I don't see, Abe, do you see any question on the chat box? I don't see any.
There is one more question by Dr. Yatendra. It is about Dr. Shrutis.
Yeah. Okay. I'm going to it. Thank you, Dr. Preeti. Yes. Dr. Yatendra Parashar. Good evening, sir. Thank you for your nice presentation, which I fully agree and endorse. What therapy would you prefer in a triple negative primary myelofibrosis in a 70-year-old male with HB6, TLC, WBC 4500, and a platelet of 40,000?
Right. Triple negative primary myelofibrosis is probably the worst scenario that we have got. They do poorly. Given the kind of numbers you've given me, a complete pancytopenia. I don't know what the neutrophil count is, only the TLC has been written as 4,500. Giving them a drug by the name of ruxolitinib is going to be a little difficult because the platelets are on the lesser side, although that's the only effective drug we have. Now, in primary myelofibrosis, if there is an established splenomegaly and the diagnosis has gone beyond a year, especially 2 years, then it's unlikely or less likely that ruxolitinib will work. In this situation, with the age being 70, he is not a candidate for a allogeneic bone marrow transplantation. So here the best bet is going to be to give transfusions to this patient as and when. You could try giving ruxolitinib, but you're going to face more transfusion because that's going to drop the hemoglobin and platelets. There are other drugs in the market which are in clinical trials and some which are getting approved, which include fedratinib as one of the drugs. But all of them have certain side effects. So fedratinib, pacritinib, they all have side effects and they are not available in our country. They're horrendously expensive when you try to bring them from outside. So unfortunately, my answer to you is that this is a difficult case to treat. Transfusions and supportive care might be the best option. And a good counseling has to be done with the patient and the family to know their options and to know what's going to be the future.
Thank you, Dr. Abe. I don't see any more questions. We have a little time. So if you're happy, we will just discuss a few things.
Sure.
I want to highlight what Dr. Abe said about a second endoscopy. When I was training in CMC Vellore, we actually had a patient just like this. And when they have angiodysplasias and they bleed, those angiodysplasias collapse. And when they collapse, they're not picked up.
Yeah.
You really need an experienced endoscopist. There's a little subjectivity element in endoscopies. I know you take the video and what have you. but still a collapsed angiodysplasia may not be picked up. So a second endoscopy is very important because your treatment, you may be chasing the wrong thing. So a second endoscopy, I would like to highlight here, especially angiodysplasias, in the elderly age group, it's not uncommon, we see it, but it's very often not diagnosed, okay? So that's one thing. Second thing, a quick comment, Professor Abe, on iron refractory iron deficiency anemia, IRIDA. Iron refractory iron deficiency anemia is something which in our country we see. We know that, in our country, milk, we all take milk. There's certain states who don't, take so much, but definitely milk is to a certain age, we all take milk, and maybe even all through life. And gluten is actually a basis and a basic food requirement for us, our rotis and our wheat. So we have seen a lot of people who come where you've given, he responds to, when you say iron refractory, you mainly mean oral. You give an IV, he may respond. Now, iron refractory, iron deficiency anemia has two limbs. And the two limbs is who responds to iron, IV, and who does not. Who does? You have things like celiac disease, which he referred to, gluten enteropathy, where unless you give IV and you actually go off gluten, they will not absorb. So you need an endoscopy to diagnose it. You need the biopsies to diagnose it, and you need the serology to diagnose it. You need the antibodies to actually establish that. But it's not uncommon, and let me tell you, for general physicians, very often, because they overdo the iron bit before they think of it. That's why I'm bringing this up. It's important, okay? And the other thing I wanted to...
Dr. Nasir, here there is a role of assessing the hepcidin.
Yeah. So hepcidin is coming up, okay? Hepcidin is actually a short aminopeptide produced by the liver. So as he's told you, it actually controls the ferroportin, which controls the entry from the mucosa into the blood. And there's only one entry. There are two entries into the mucosal cell, one entry out. So the one entry out, hepcidin controls. And hepcidin levels actually inhibits iron absorption when it needs to, and helps in increasing when you have deficient states. So hepcidin actually is going to come into play as a clinical agent, as a pharmacological agent.
Yes.
But I'm sure it's going to be shorter than what one thinks. But the hepcidin antagonists in certain conditions, and hepcidin itself as a molecule, I think is very important, and one can actually have a short talk.
And there is a TMPRSS6 gene which has been identified, which actually increases the hepcidin levels.
Yes. So you have hemochromatosis, hemosidrosis on one side, and you have the deficient states on one side, and you have thallasemic syndrome in between. Which whether
that could explain why there is iron refractory iron deficiency.
Yes. So hepcidin is a huge role. So he has preempted very smartly my next question. That would have been my next question. Okay. Now coming to IV iron, it's a little tricky here. In the older days, iron dextran, he said intramuscular, enough is used now. We all use IV. And he said that we use FCM, ferric carboxy maltose, iron sucrose, and the maltose, derivative.
Isomaltose, right?
It's in the market now. Okay. Now, there will be a lot of pharma-driven issues and actuals. So go by the actuals here, okay? And he's also told you about the molecule. The carbohydrate moiety decides a lot of the, immunogenicity, antigenicity, anaphylaxis, anaphylactoid reactions, and what have you. And many of these says given in 15 minutes, some says given an infusion for 30 minutes. I always tend to give it as an infusion, and I never am in a hurry to give my iron, because if you see one, don't forget, most of us are busy in our OPDs, and patient with allergic diathesis who's stable may not even volunteer the information. And in your worry about 40 patients in your OPD, you may not even ask it. while allergy is always a component in all the HIs of every hospital, it's a column and a row. You have to say nil. But if he is got allergic diathesis and you push, the sister says 15 minutes and she just pushes it. I have seen anaphylaxis and anaphylactoid. They two are different. Anaphylaxis is IgE mediated, anaphylactoid can be non-IgE mediated, but equally bad. Okay, so you must know that. So that's one thing. So your preference, Abhay, when I have to use an IV preparation, what would you recommend? I'm not saying it's a pharma preference. I'm just saying as a molecular preference.
So I've been using a lot of ferric carboxy maltose. I used to use iron sucrose when it was available. My problem with IV iron sucrose was that it needed often for the patient to come to the hospital or daycare and take it for the full dose. And I was very happy when ferric carboxy maltose came to the market, where I could give a larger dose in a smaller period of time. So typically I'm giving 1 gram in the first visit and 500 milligrams in the second visit. And like you, I also give it as an infusion. And I give a small write-up about the iron. And I always tell them, please read about the iron before taking it. The reaction rate is very less. It's 1 in 1,000 or something of the sort. But for the person who has it, they'll always remember that reaction.
1 in 1,000 is not for me. Why should it occur if you preempt it? So that's the message.
Yeah. So that counseling has to be done in the OPD. I tell them to have, I tell them to have a banana a day, because, phosphorus goes down in these patients, and we actually don't have an oral phosphate. So typically available. So I give a banana a day, and I give them all the warning signs when they should come back to me. Mainly joint pains, fever, rash. These are the reasons why they should come back. I ask them to check the blood pressure at home if they're feeling giddy. Usually I involve a general practitioner or a member of the house if they can take a blood pressure at home with a machine to then inform. So far, my callback in the last 4 or 5 years of using it, especially in the last 1 year since COVID, last 6 months since COVID, has not been much. They have a little bit of aches and pains. They take paracetamol. But one of the girls was upset with me because she became dark. IV iron can cause darkening of the skin, and she was a little upset. She was a young girl, fair and a model, and she was upset with me because so I now include that in my little bit of discussion which I give the patient, that it could cause skin discoloration. So my fairer girls, I do make a mention of it. I'm a little bit concerned about that, so I make a mention. And I tell them that these events
I hope she didn't lose her job.
No. It was manageable. But you have to counsel them before we give.
Yes.
And second thing is, we should prove there is iron deficiency. Although reaction rate is very less, but that doesn't mean we abuse it.
So that is the point I am going to now highlight. It's available freely. There is no stringency. There is nothing stopping you. You got a license to use it. Every physician can. Since we are talking to a large landscape of physicians, I would say it's more important to know when you should not give it.
Yeah.
Because that equals to abuse. And if you abuse the iron, actually you may have to pay for it. So I think you should not use it loosely, just saying, oh, give her IV iron. No, you have to establish, like Dr. Abhay so nicely brought out, that there is a need for it. And he so nicely showed you in the chart what are the levels of deficiency. Okay. So I think no abuse should ever occur. The other thing is I want to ask you, pregnancy. A patient comes with rheumatic heart disease, pregnancy, second, third trimester, low hemoglobin, and you want to catch up. And what is the things you do for oxidative stress? Because IV iron is one of the agents which actually also causes oxidative stress. So my concern is with cardiac patients, and physicians manage it. Like a patient with IHD with angina comes with, he's on aspirin, he's bleeding from the gut, and he comes with a 6 gram hemoglobin or 6.5. He's symptomatic. And the first thing the physician does is, okay, shoots up 1 gram of IV iron. So here he comes back with a cardiac arrhythmia. I've had a patient like this. They give an IV iron and he comes out with cardiac arrhythmia. So be a little careful here. The caveat is it causes oxidative stress. And there is a cohort in the geriatric patients who have cardiovascular problems. And be very careful there, especially there. So, you must be careful that it's done under the right conditions. Admit him, monitor him, give it in small aliquots. You don't have to give him 1 gram straight away. Even if you give, even like iron sucrose, what did you do? 100, you can keep going, 500 you can give. So then, you're not repleting a total iron therapy here. So give the lowest dose possible, and he only requires a few milligrams per day. And he's still going to form only so much hemoglobin per week. Whatever you give, he's not going to suddenly become 12 grams, you see? So his response time is going to be the same. So really speaking, go slow here. So that's not written in the books. That's why I'm telling you. Okay. Then I want to tell you about, very important thing with Dr. Abhay brought out, our practice of foodstuffs. We have multi-deficiencies and we all take a lot of milk, and milk is laden with calcium. So he takes an iron pill and he pops up a glass and a half or 2 glasses of milk. And we know calcium, phytates, tannins. The older person in the Northeast, he will be chewing a supari after that. Or, having his black tea. They're all absolutely binders, and they all chelate, or just you exceed the iron you have taken. And you know that only certain percentage is absorbed. So diet is so important. So Dr. Abhay said he prefers after meals than before meals given, because, different subsets have gastric irritation, especially pregnancy and certain children, So really speaking, that's not bad. But, all of us in our lunch take yogurt and very often take milk in the night. So a little caution, and the elderly take calcium because of osteoporosis and osteopenia and different situations. So just be careful about the dietary things, calcium-related things, and the food, especially tea, phytates, and your betel nuts, your suparis, and your tea. So,
Dr. Nair, can I make a comment over here?
Yes.
I've had patients who want to take oral iron, but genuinely cannot handle it compliantly.
Yeah.
And they genuinely cannot afford the IV iron.
Sure.
Or they are anxious about taking IV iron, coming to hospital, needle being put in, and they are averse to needles.
Yeah.
So here, the concept of using a lesser dose of iron in a different form, be it an editate or a sucrosomial iron, and sometimes making the iron alternate day. Now, there is a theory behind this alternate day. So like I showed in my that beautiful absorption diagram, that cartoon which I had got, if you take a tablet of iron, is going to be absorbed and it will go inside through the ferroportin into the bloodstream. This will stimulate the hepcidin to increase.
Yes.
And what will happen the next day when the patient takes iron?
It's inhibited.
The hepcidin will be higher. So it will tell the ferroportin, don't take as much. So now your patient's gut is exposed to the same amount of iron, but the absorption is going to be lesser, which means now I'm going to face the toxicity of oral iron rather than the benefit of the absorption of iron.
Absolutely.
So in this situation,
yes,
if we can give it alternate day, sometimes you can keep fooling the hepcidin and maybe we can get away. What do you think?
So right. So I use it actually bi-weekly in such situations. I even go one step ahead. I use bi-weekly. Number one. Number two, it has been shown the NEPI program, which is the the national program for iron supplementation, compared to the global guidelines, was using it every day. And they stepped up, from 20 to 100 requirement for elemental iron. What do they find? Toxicity. And compliance went down to less than 20%. So the whole purpose was failed. So remember, what is the ultimate aim? Is to get something in. So bi-weekly, taken rightly, is the way to go, rather than stepping it up. That's so very important. So I think the more we say about it, I think we would emphasize more on it. And the average man does not take time 2 minutes in the OPD to advise this patient on it. I think that's so very important. Then I come down to the very important thing of, thaltrate. The so-called thaltrate, it's a curse of nature, but it's a huge burden on the family. It changes the family's lifestyle and hurts the other children who are normal and drains the economic state of the family and the nation as a whole. So I think this curse has to be addressed by us. And I actually am very vocal about this. And I think what Dr. Abe said, you must read it 10 times. And what happened, what is missed is when they coexist. When they coexist, you do a test, you say it's negative, maybe a false negative, he's also he or she is iron deficient, so you don't pick it up. So really speaking, I think you need to know that we are a deficient country and we are the leaders even in deficient countries, even for iron deficiency. So coexistence is not unknown, and low socioeconomic status, it's a rule rather than the exception. So you must do that. And Dr. Abe showed, I have a few more minutes to play around with. Dr. Abe showed a very nice example of alpha thalassemia. The case, Ignat, which you showed, where the HbA2 was normal, electrophoresis was non-contributory. Now, my one comment and a question is, how do you differentiate from a severe iron deficiency coexisting with this without iron studies?
So usually the thalassemia traits usually have a better RBC count. And in typically iron deficiency anemia, which is significant, the RBC count will drop. And the RDW is not as high because, all the cells are similar in size in iron deficiency. But one of the thoughts is RBC count. If the RBC count is low, I'm more likely that there is a iron deficiency lurking in a thalassemia. And look at the MCHC. If the MCHC is low, it's more iron deficiency. If it's normal, it's more likely to be thalassemia, alpha or beta. If there's a combination, I don't want to put too much effort. I want to first treat the iron, try to bring up the hemoglobin, then the truth will be known. And, like you and me have discussed, there is no rush in diagnosing beta thalassemia or alpha thalassemia.
Absolutely.
They're from birth. Take your time, but diagnose it well, because they're going to take your paper around everywhere saying I'm not thalassemia.
So that's the other thing I want to underline to all the students on the platform, that don't be in a hurry to push in IV this, IV that, get 10 tests done. See the peripheral smear and the CBC, you got most of the answers. And just go through a trial of replenishing the deficiencies. Repeat it after a period of time like has been highlighted, and then readdress, get the patient. So there is no hurry. And you must put this 2 points in the discussion that you definitely like to review the patient. Don't lose the patient on follow-up.
Yes.
That's the important thing, okay?
One thought in pregnancy, if I may, Dr. Nair.
Sure.
From about the 18th to the 24th week of gestation is a time when iron is going to be distributed to the fetus through the syncytial trophoblast. And by the 32nd week, iron transfer will be complete to the fetus. So it is imperative that as practicing physicians, we pick up iron deficiency in that phase between 18 to 32 weeks. And we should be able to provide iron either orally or intravenously to our iron deficient mothers so that the fetus is not depleted of iron. Because there's a fantastic studies, may I say, of children born to iron deficient mothers. And what are the kind of outcomes they have had? They have been slow to mentally and physically, and they've always had a poor quality of life. And this is not something we want in our progeny for our future. So picking it up in that phase and treating the pregnant woman with iron is extremely important. And for those who are seeing younger, especially the physicians, you must, when they're married, 2 things. One is assess their iron status and, check their thalassemia status. Because I don't know how to go about this, how to impress the population or the community that this is in your interest to know how your health is. If iron deficiency anemia is so common, why are we not addressing it at a community level? We should be, knocking on doors. We should be yelling on rooftops, trying to make these people understand. But somehow, either we are not able to do, or the patients are not receptive and thinking this is another, unnecessary gimmick. I don't know. What do you think, Dr. Nair? How do we go about this?
Yeah. So it's such a paramount question and affects the country as a whole. And I addressed this when I was in the armed forces, at the armed forces level, which is we also have a population serving an ex-service in touching 15, 16 million. So we have a large population. So I could actually study and address it. I have 2-3 comments here, and then I'll also address what Dr. Abhay said. One is the brain formation is at its peak from 0 to 3 years. And the fetus is a parasite, so to say the wrong word, because it's a gift of God, but it will leach off iron, even an iron deficient mother. He's told you about this, about the time when they actually transfer and complete by so and so time. But even iron deficient mother, they're going to leach off the iron, but they will still be deficient. And from IUGR, intrauterine growth retardation, to small 4 dates, to prematurity, to intrauterine deaths is known. It is much higher. 20% maternal mortality already Dr. Abhay has said. Scholastic performances, beautiful studies. In the first 5 and 6 to 10 years has been shown is low in these children who've been born such, as we have just told you, compared to the peer group. So you have blunted the scholastic performances. So in other words, you have blunted the next generation. So the community has to participate. And I actually have even shared this at various levels of the government, that we have to not only cry from the treetops and the rooftops, we actually have to deal with families at the community level and the so-called primary health center, which we have. We have to have the health workers in this NEPI program, which is actually a reinforcement program to give iron. But we need the counseling part. We need the audio visuals to say what happens if you don't. And what happens if you have gastric upsets? What happens? What are the alternatives? So all those have to be made. The so-called, we need to watch the IPL, I agree. But this is what is required for the pregnant lady. This is what is required for the husband, the children, and the grandparents, and the nuclear family to see, and the community at large to see. So community has to be addressed. So correctly brought out. Public health. COVID showed us we can do firefighting at the fire end. Unless I find the cause of the fire, it'll come again. It'll come again. It'll keep coming. So public health is addressing that. Let's find the short circuit. Let's find the fuse. Let's find the spark. The smoke is never there without a fire. So that's what we have to do here, ladies and gentlemen. You're the future. You've got to address that. And I actually, could go on, because it's such a topic where Abhay and me could actually go on for a couple of hours on this topic. But in the interest of time, I would like to say that we've had a wonderful exposition of a very difficult topic, considered common, but very uncommon in our practice, how to correctly approach it. And that's what Dr. Abhay has told you. Listen to this talk again and again, maybe weekly into 4. I'll talk to you after that do you have to see it again. And with that, I want to thank Dr. Abhay. I want to thank him for the wonderful exposition, which I've said many times. And I want to thank NAMS for having made this possible. Our president, Dr. S.K. Sareen, very energetic secretary, Dr. Kapil, and our coordinator and educator, Dr. Professor Sood, and Dr. Preeti, for having coordinated and actually disseminated this to make this possible. And once again, I would like to end by thanking all the participants and the interactions. We would love to have more. So, because it's such a common topic. And that's what I said, community. You are part of the community, but your response has been 0.0002%. P goes to 401. So very significant in the insignificant responses I've got. So to put it bluntly, you've got to be there, ladies and gentlemen. So let's see if you perform better in the next talk to audit you with a pleasant surprise, maybe in the next talk. Thank you, Dr. Abe. Thank you, Professor Sood.
Thank you.
Thank you, Dr. Preeti. Thank you all, dear delegates and participants. With that, I would say a big Jai Hind.
Thanks.
Thank you, sir, for such a wonderful talk. And there were so many practical tips and which I also would be using in my patients. It was really helpful. And I would like to invite Professor Ajay Kumar Sood, sir, to provide the vote of thanks.
Oh, thank you so much. I think National Academy of Medical Sciences is extremely grateful to the speaker, Dr. Bhave sir, for covering this complex topic in a very simple and comprehensive way. You have shown the spheres, diagrams, and also shared your experience of years in the form of cases. I'm very sure that our participants have learned a lot from that. So we look forward for your support in future also in the form of NAM's faculty mentors. Thank you so much, sir. And we are extremely grateful to our Honorable Council Member, Lieutenant General Velu Nair, sir. Your presence always has been a source of encouragement for all of us. You have been always supportive for the academic activities of the board. We are extremely grateful to you for kindly agreeing to be the chief coordinator for these series of lectures. And we assure you that under your guidance, the Academy will try its best to increase the number of students as well as to introduce more innovation in this Navigate CME program. The fact that you have stayed throughout the session, so that itself, I think, is a source of encouragement for all of us. We are extremely grateful to you, sir, for your presence. I will also like to thank my colleague here, Dr. Preeti. She has been always helping us in the background, and you're extremely supportive. Despite being busy in your specialty, you have always will find time for having this session. Thank you so much for your support. And IT support, which has been provided by Mr. Ravi and Mr. Anil from NAM's office. We appreciate that. So once again, I would like to thank all of you for being with us this evening, and we look forward for another interesting session on 3rd of June. Thank you very much. Jai Hind.
Thanks. Thanks.
Thank you all. I declare today's academic session closed.
Thank you.